Hello, and welcome to this session on non-clinical or social determinants of health. Social determinants of health are, based on the World Health Organization's Commission on the Social Determinants of Health, those conditions in which people are born, grow, live, work, and age, and the fundamental drivers of those conditions. So essentially, it's what conditions you live in and why those conditions exist. They're also known as social drivers of health, which emphasizes the point that many of them can be changed. These aren't permanent or fixed things. Some are, some are not. Most of them are structural in the environment that someone lives in, but they are changeable. They're also sometimes called non-clinical determinants of health. And this basically is to differentiate these factors that impact patients' health from all of the things we think about the conventional medical system addressing. And we'll talk more about this in the next slide. So when we look at what impact traditional healthcare, hospitals, primary care offices, specialists have on patients' risk of premature death, we see that healthcare in that sense only contributes about 10%. Genetics contribute about 30%, and as we continue to move forward with understanding genetics and understanding how to change some genetic risk factors, that will slide more into that 10% of healthcare. Individual behavior impacts about 40% of the risk of premature death. So what we do in terms of risk-taking behaviors, both explicit, the hold my beer and watch this type of risk factors, and the this is my beer, these are my cigarettes, this is my sedentary lifestyle. So that is the behaviors that influence outcome. And as you can see, that's actually the largest risk factor for risk of premature death. And then finally, social and environmental factors, what we would really think about as those social determinants of health, although many individual behaviors are the result of those other social and environmental factors. So when we break down social determinants of health into major areas of impact, Healthy People 2030 identifies education access and quality, healthcare access and the quality of that healthcare, the neighborhood someone lives in and the built environment that they live in, their social and community context, what their networks are, and their economic stability. And if you look at the Kaiser Foundation, they also add food, which you might put into economic stability, but they really call that out as a major influencer in and of itself. So we think about either these 5 or these 6 major areas of social determinants or non-clinical determinants of health. And so why do these matter? Well, if we look at the consumption, basically the amount of spending, consumption on health in the US, we see that we in the US have the highest total health consumption in GDP. This was 2013. It continues to go up, higher than any other comparable industrialized country. And you can see that we spend a fair amount on social expenditures as well, and that includes healthcare. So we're spending about the same as most other countries, 29% of total GDP on social expenditures, including healthcare. But our share of it is that 10% of influence on health, our major share. Over half of it goes towards paying for healthcare. But what does all that extra money paying for healthcare as opposed to the net total social expenditures get for the U.S.? Well, Um, versus comparable countries, we have the lowest life expectancy at birth in years. So we're not getting longevity, even though we're spending about the same or a little bit more total between healthcare and social services. Our extra expenditures on healthcare is not getting us longer lives. If we look at what other influencers might be at play, we smoke less than comparable countries, so that lifestyle piece isn't necessarily that important. But on the other hand, if we look at our age standardized disability adjusted life years for lung, tracheal, and bronchial cancers, which would be the ones that would be attached to uh, smoking, we can see that we're at the top. So even though we have lower cigarette consumption, we have the worst outcomes in terms of disability adjusted life years, how much we are disabled by that behavior of any of the comparable countries. When we look at alcohol, we have below average liters of alcohol consumed per capita, but our age standardized disability adjusted life years, again, the impact of alcohol use is we're second highest, only behind Germany, and much higher than other countries have much greater consumption than us. So our behaviors have a greater impact on our health than in other countries. Think about the implications of that. Doing the same unhealthy behavior in the US causes more unhealth than doing that behavior in pretty much any other industrialized country. The Gini coefficient is basically a ratio of wealth poverty, and the higher that ratio, the greater the disparity. So you can see again that the US has a greater disparity between wealth and amongst the highest earners and the lowest earners, and that may have implications for why our behaviors, our at-risk behaviors, are more impactful in the US than in other countries. And then if we look at total population covered by some form of health insurance, this 2016, the numbers, at least the orders, really haven't changed. You'll note that in most industrialized countries, it's close to or at 100%. The comparable country average is 99.9. The US is 91.2. That's great. That means about 9 out of every 10 people are covered by some type of insurance. But that also means that about 10% of the population isn't. And that is true for a lot of different reasons. But again, when you think about our health outcomes, correlation isn't causation, but this is a pretty strong correlation. If we look at the prevalence of obesity, it's much higher in the US. So this may be changing now with the GLP-1s. They are in some ways miraculous drugs for treating obesity, but keep in mind that obesity as a standalone treatable medical diagnosis is one that has not been well recognized in the US. So even though it is a tremendous contributor to other illnesses, it's been thought of as a behavior as opposed to a medical diagnosis, and is much higher in the US than other countries. While there are places there people get less physical activity, less exercise than in the U.S., we are in the upper half. We are above the comparable country average. So that could be, you could say that's a behavioral thing, but on the other hand, if you're working two jobs, when are you going to have the time for sufficient physical activity to remain healthy? You're not. So when we think about these impacts, the social determinants and the social needs, we think about at the very low and the downstream end, that's where we're providing the clinical care that makes up for the fact that all of these social factors, these non-clinical factors have impacted health. Um, we often try to be in the midstream, so we're working on individual social needs, and that's a lot of what you'll do in your role as a community paramedicine practitioner. But there are upstream community level impacts as well, and even though you don't necessarily need to be concerned about them as you are doing your immediate work, you should be thinking about them, being aware of them in terms of your potential for larger impact of being able to support health more broadly, to decrease the need to intervene at the individual level or respond to the diseases at the healthcare system level. Thank you for your time and enjoy the rest of your learning.